This conference will now be recorded.
Hello, everybody. It's John Antonucci. This is AnCan's high-risk metastatic advanced prostate cancer discussion group. Welcome. We are going to record this session. So if you're concerned about your name or your picture being on, you can do something about that right now. We're grateful to Telix, Blue Earth Diagnostics, Foundation Medicine, and Novartis for helping support our group. We're going to exchange a lot of ideas and experiences. We're going to avoid giving medical advice. So if you hear anything of interest, please discuss it with your oncologist or your treatment team. And there are several other moderators on the group with me tonight who will be helping me. Rick, Jim, who else I got here for moderators?
Len,
and Stuart.
And Stuart, yes.
Okay.
Thanks, and for those of you who don't know Stuart, you may not. Stuart has several claims to fame, but amongst them are the fact that he's on our board of our executive board, number one, and number two, he's one of the co-moderators for the low intermediate group.
So Brian and Carlo, the way we proceed is we first introduce new guys to the group, and Brian will take some time to get history from you, although some of us already know a lot about you. I think Stuart's here to back you up. And then once we get through that, we'll start going down the list. I have almost 15 guys who want time tonight, so we're gonna keep it moving right along and do our very best to get to everybody. So Brian, Stuart, how do you want us to proceed introducing Brian?
Brian, I know, is ready to go through the basic facts with you.
Okay. Where are you from, Brian?
From Seattle, Washington.
How old are you?
66.
And have you've already been in Stuart's group for a while? Is that true, or do you know him from outside of AnCan?
I've been with active surveillance and low to intermediate groups for 7 months. I go to all the meetings. That's where I know Stuart from.
So you actually got quote unquote promoted to our group.
Yes, I got promoted.
Good for you.
I didn't want to, but, you know.
Sorry to hear that. What's your when did you get diagnosed?
I got diagnosed the first time October of 2025.
Tell us about it. What happened? What got you diagnosed?
From 2020, I'll keep it short, Rick. 2020, 2025, I had BPH. Seattle VA, I'd get all my care through Seattle VA. PSA was always 3 to 6, normal DRE. Couldn't pee for 600 straight days, so I had to self-catheterize. Finally, I had the aquablation in October of 2025. Urologist Dr. Martin Wall at Overlake Hospital did it through community care. Took out 20% of the prostate, said 70% was tumor, 3+4. The 4 was only 10%, and it had PNI. The DRE right after that, it felt hard on the right side. Then I found AnCan last January. And so I had to wait 7 months to get a transperineal biopsy, which I got the VA, they took care of that at the University of Washington. So I got that done 3 weeks ago. Done by Dr. Rand Wilcox Vandenberg. All 12 cores were positive, 80 to 100% full of cancer. 4 were 4+3, and 8 were 3+4. They all had, they had large cribiform, intraductual carcinoma, prostatic extension, PNI. Dr. Epstein confirmed everything. And then I saw a radiologist, oncologist at last Monday, and he sent me for a PSMA last Friday. So I did my PSMA, and you know, I'm kind of looking at that right now. So it says it's gone through the lymph nodes and the other
Go ahead, read us the summary of the report.
I don't have, well, I have, but I don't have, I mean, it's like this. It's like the chest area, the abdomen, the pelvis. I sent it to the moderators. I didn't know you'd want me to read this.
No, that's okay. I just want to know. So it sounds like you have metastases in your chest and abdomen. Are they all in bones or are they in soft tissues?
I just opened this up Monday, so I just got
Yeah,
it.
I understand.
All
Yeah.
right, so let me help out, or Stuart can help out. Okay, so, there are, I can't tell you exactly how many. You have a copy of this, Dr. John. I sent it to you and Len last night. I think there's about 4 or 5, maybe 6 locations. 2 of the locations are in the ribs and they're very low SUV. So this is sort of, that part is somewhat reminiscent of Avery's situation. They're like 2.5, 2.6. However, there are at least 2 lymph nodes. I'm doing this from memory. One is an interior iliac node, and the other is a what was the other one? It's I forget.
Right lateral sacral lymph.
That's it. Sacral lymph nodes. Thank you. I don't have it open in front of me. And both of those are relatively high. One is 7 point something and the other is 10 point something. What are the 2 SUVs on those 2, Stuart?
Right lateral sacral is 15.8. Right internal iliac is 10.7. There's also a multiple right gluteal 11.
Right. And did we miss any other key points? Because you have it open there.
There are a couple more. There are a whole bunch more nodes. There's a 7.6. There's an 8.9.
Okay.
So there's like 5 or 6 with high single or double digits, and then there's like 3 or 4 more nodes that are 3 or 4s.
Right. So the situation that we're facing is probably, and this is what we'd like to discuss in the group, what Brian would like to discuss in the group, is that the PSMA, Brian's probably been dealing, the cancer's been there quite some time. He's been dealing with as he mentioned, he's been dealing with the BPH for 600 days, which during that time, the cancer obviously grew. We found it through the aquablation. I don't know why. Brian, you haven't talked about your PSA history. What was your PSA history during that period from when this all started right through to the...
Basically, the PSA basically was like in 2020, it was like 3.3, then it went to 4, then it went to 4.5, and then 5, and then it go back down to 4. The highest it's been is 6.4, and I took it right to biopsy here with 6.3.
Okay, so that's obviously an important factor for us because he's a low PSA guy with a significant amount of cancer, so that is a clue. And the question now is, what does he do next? My guess, and I don't know, and I haven't heard, but my guess is he'd be considered a T3B, because these are all interior, possibly T4NX. So either T4NX or T3B, and interested to hear what you guys would have to say about that. And does he do treatment, interventional treatment, some sort of radiation most likely, and hormone therapy, or does he just do hormone therapy? We have recommended that he see a GU medical oncologist, probably at Hutch, because he's getting to Hutch through community care. They say he has to see a radiation oncology doc first. Love to hear from any of you. We've got Steve. We got two Steves from Seattle in here, both of whom might have ideas on a radiation oncologist who he should see. We need to know that in a hurry because he may already have been assigned, but he can switch because he hasn't seen him yet, because I don't have a good name for him. And we've given him three possible names, Dr. Schweitzer, Dr. Shea, and Dr. Yastrzemski for GU medical oncologist. So in a nutshell, that's where we are.
Okay. Excellent. You probably never got any gene testing, did you, Brian?
I've been telling all my doctors, and I finally got the last one to put it in the notes at the VA. Says that he's going to request it. He doesn't know if they can guarantee it. So I'm on.
Okay.
I'm on it.
And you haven't had any treatment yet, right?
No treatment. And my Decipher score is 0.91.
Decipher.
I think we mentioned to you on that Decipher 0.91 that it'd be a good idea to get hold of the grid report, which your doctor has to order.
Yeah.
And we can help you interpret it.
My urologist just told me the one that did the biopsy, I talking about that, he says it's not going to make any difference on treatment. So he's flat wrong. We heard this yesterday, and I will tell you why. I know.
And the reason is because, and you can tell him, the reason is because, and Dr. John knows this a lot better than I, so maybe I should let him answer, but my understanding is that grid report may give us an indication as to certain mutations, somatic or germline, that are seen. Now, you're going to get a germline test, which will only tell you what you inherited. We're not going to order a somatic test. The Decipher may give us a clue on what other mutations may be there. So, for example, in that group last night, we had a guy with a grid report, and it looks like he's carrying P10. And that's going to be really important information for him when he sits down with Dr. Dorff at City of Hope this week. So your urologist probably has never even seen a grid report, and he doesn't know what he's talking about, because if we see certain of those mutations, it may influence the treatment decision.
Exactly. I'm agreeing with you.
Dr. John, you're really familiar with the grid reports. What do you think can be pulled out of these grid reports?
The grid report has the Decipher itself is a prognostic test. It tells us how the tumor might behave in the future. And yours tells us that you have a very high chance of metastasis. Well, we already know that because you already have discovered that you have metastatic disease. It also has some predictive information. It'll give us a little bit of, it's probably going to say things like, ADT hormone therapy alone is insufficient, something like that. Well, we kind of know that already anyway, because we know that you're metastatic. It might give us a little clue about whether something like immunotherapy might be thought about in the future. If they do this Portos part of the grid report, it might make some predictions about radiation. Maybe your radiation oncologist might want to say, increase the dose because you have intraductal carcinoma, things like that. So there'll be a number of things that might sway your doctors one way or another as far as treatment, either your radiation oncologist or your future medical oncologist. So, so here you are, you're metastatic right off the bat. You're only 66 years old. You're probably a little bit shocked still, even though you've been struggling with this for a while. You didn't really get this cancer diagnosis until recently. But there's a lot of experience, very, very much like yours, in this room. And what you're going to be going through in the next year as far as hormone treatment, radiation treatment, I don't know about chemotherapy treatment or anything like that quite yet, but we've all been through it. And so we're all going to support and walk you through the whole process, side effects, things like that, and make sure you get rigorous care. What's the most pressing question? Oh, you haven't actually seen the radiation oncologist yet, right?
I did see one at the VA. He also works at the UW. But he's the one that got me. I saw him last Monday. He got me the PSMA on Friday because he was concerned. But he doesn't really work at the UW, so I'm going to be seeing a new one.
Oh, okay.
Tomorrow.
Okay. All right. So they're going to be talking to you about things like you probably have too many metastases to try to shoot them down individually with spot radiation. We're going to probably be relying on whole body systemic therapy for those. But you do have a number of pelvic lymph nodes that might be covered by a radiation oncologist doing the pelvis and the remainder of your prostate gland. So we look forward to that radiation oncology treatment plan. It's, I think, pretty likely that radiation therapy is going to be on your ticket in the future, even though you have all these individual mets that will not be reached by radiation oncology.
And my one thing is, I talked to Captain Jim about this on an email. We've gone back and forth. A lot of great information about. I think the VA only does Lupron, the shot injection, and everything I've heard from you guys say that's not good. You need to do Orgovox. So that's what I'm trying to figure out now. I don't think Medicare. I'm 66. I don't think Medicare pays for it. I don't know if the VA will cover it, but Jim Marshall gave me a lot of good information on how to proceed with that. So if anybody else knows anything, that's good.
So the issue, and Jim Marshall is in the meeting, so he can chime in. The issue is that not all the VAs offer Orgovyx. I mean, it seems silly and crazy, but some do and some don't. And we don't know why. Now, if the Seattle VA does not provide Orgovyx for you, then it's an expensive drug. It depends on whether they're going to provide the other drugs. If you cannot, the most that the Orgovyx is going to cost you, in fact, all your drugs are going to cost you, is about $2,600 out of pocket for a year. Because on Medicare, you can't pay more than that.
But I don't have Part D. I just got A and B.
So you have never signed up for Medicare. You've just got A and B and the VA. Is that right?
Yeah, because the VA takes care of everything. Yeah.
Okay. And
but I could sign up.
Well, you can sign. I think you can sign up.
In October.
There are other issues. I don't want to get into that right now, but the longer you delay it, the more expensive it becomes. And we can talk about that with you, but I'd rather just focus on your diagnosis right now. And if they're going to give you a shot pretty soon, the Orgovyx, if you cannot get the Orgovyx through the Seattle VA, then I would say the first shot should be Firmagon and not Lupron, and then switch to Lupron afterwards.
Okay.
Switch to Lupron.
That's the way I did it. It's perfectly good. It was before Orgovyx was invented. If you have serious heart disease, we might make a big stink about trying to get Orgovyx, but if you don't, don't feel that you really got a bad drug or anything. It'll still treat your cancer.
Well, I do have the heart issue, the new heart valve, and I got permanent AFib, a couple other things. So that's another issue. So that's
So you've got permanent AFib, right?
10 years. Yep, 10 years. And I got a new aortic heart valve, tissue valve about 3 years ago. They put a new tissue valve in.
For aortic stenosis?
Yeah, yes, it was a bicuspid valve.
Oh, you have a bicuspid valve. Oh, yeah, okay.
They gave me a new one. The VA, they did a great job.
Great.
UW
How many years ago?
Pardon me?
How many years ago did you get that valve? 3 years.
So I would say we can make a good case for you to get Orgovix.
Yep.
And you may be able to get it working with whoever you're working with at the VA. I don't think that, but it's possible
Online.
that if it's guys, can you please mute if you're not if you're not talking? What I really want to do is get a name for you for the radiation oncologist, because yesterday you told us you've got to see a radiation oncologist first. So any of the Seattle guys, we've got David D, we've got Steve S, and we've got Steve L that I can see. What recommendations do you have for Brian in terms of a radiation oncologist at UW, at Hutch?
It could be at either one, I think.
Yeah, I just put who mine were in the chat. I don't know the status of Jonathan Chen now. That was a couple of years ago.
Jonathan Chen moved up to the Northgate.
Yeah, he moved to Northgate. Just found that out.
Martin Ma was I would recommend him or Dr. Martin Ma, who's my last radiation guy.
That's great. So Chen is one alternative and Ma is another alternative, Brian.
Okay.
And Steve S, were you happy with Chen?
Yeah, it was. Yeah, I thought he was really good.
Okay. Steve Logan, who did your radiation for you?
The people that were offered to me at Fred Hutch were all had pretty small amounts of experience. So I actually went over to Swedish and used Robert Meyer over there.
Okay.
Robert who, Steve?
Robert Meyer.
Yeah, I don't want to muddy the water, John, because right now we've got community approval for Hutch. So let's stay in UW Hutch and not introduce Swedish, because if we do, we're going to have to start. We're going to have to reinvent the wheel with Swedish.
All right.
So I think Chen or Ma are both good suggestions, based on Stuart and based on David and Stuart. Sorry, Steve.
When I was talking to the intake lady at Hutch yesterday, I think it was she did mention Jonathan Chen, but he works at Northgate, like Steve was saying. But so it'd be okay to go to a different hospital. Is that Northwest Hospital, Steve?
It's just a branch of UW. I mean, it's affiliated with Fred Hutch. It's just they have different equipment up there, I guess. Yeah.
Okay, I'm working on it.
Okay.
So
tell me about your social support, your lifestyle, your diet, your exercise, the things that support our general health.
My diet is I walk 4 miles every day, pretty hard pace, 4 miles, 6 days a week. I've cut back a lot of the crap. I talked to I do a lot of support. I go to the Providence Hospital in Everett every third Wednesday. They have a cancer group there, guys that have their prostate out, they've had radiation, all that stuff. So I go there every third Wednesday in person and do all the AnCan meetings. My girlfriend's supportive of my family, so I think I'm pretty good there. I need to start lifting weights. I think I'm like, God, I got to start because I don't do any kind of lifting or any kind of for that.
Yeah, you're probably gonna end up on some sort of hormone therapy. So lifting weights might help to keep your muscles from wasting very much.
Is it too late to start that?
No.
Okay, I do walk the 4 miles every day.
Yeah, that's excellent.
I was doing 3 miles every day until I talked to David Sharp, and he said you need to walk 5. So I increased it to 4. Worked my way up.
Yeah, he slave drives me to also.
He's great. Yeah.
Be sure to ask your docs for a bone density scan right now.
Before.
Yeah. And the other thing that you need to get right now is a measure of your testosterone.
Okay.
Yeah. I was just going to add that. So Fred Hutch, for some reason, does not measure your testosterone before you start hormone therapy, which is quite aggravating because when you want to get back your testosterone, what's your target? And you don't know.
Yeah. Yep.
Okay.
Great idea. Also, they're probably going to combine 2 drugs in your hormone therapy, possibly 3. And oftentimes they'll reach for a drug called abiraterone as the second-line drug. We think it's a little provocative with atrial fibrillation, and maybe would rather see you on a different one. So talk to us after after you find a medical oncologist, and you're going to get on 2 or 3 drugs, and then just make sure they know all about your cardiac condition.
Yes. Okay.
And those are great suggestions that Rick made as well for getting a baseline for the future.
Yes. Sometimes you don't need that, because I'm dealing with the VA,
Yeah.
You don't need
I know.
But like they wouldn't give me the transperineal biopsy. I said, that's fine. I asked 3 of my doctors. So I went down and talked to the advocate office down there, and I ended up getting it. It took 6 months, but I got it.
Wow.
So I got it. Yeah, it took a while.
All right.
This is my job, so I'm going to do whatever I got to do to get this thing done.
You're not still working?
No, I'm retired 6 years ago.
Okay, great. Yeah, you can.
I'm listening to you guys because you guys know what you're talking about, and I appreciate you guys.
Okay. Very good. Well, I'm glad to see you being real active with this, because you have the potential for a quickly moving cancer here. So we're not going to sit around anymore, right?
Oh.
Very good.
Well, yeah, and I think the other thing that we want to say to you, Brian, is that this isn't the best diagnosis, but it's certainly not the worst. And there are so many ways to treat this disease. There are a bunch of gents sitting in this room right now who had a worse initial diagnosis than this, and they're doing great. And the view that we would encourage you to take, and I think before we leave you, we'll just ask quickly for anybody who wants to comment to say something to you, is you got to look at this like a chronic disease. You could be living, another 25, 30 years even, if you manage this disease correctly. So we've got a few hands up. Please keep your comments short, because bearing in mind that we've got 15 people to follow, and we've got to get out this room tonight because MS is coming in after us. Go ahead, Jeff Markey.
Yeah, I just wanted to mention, I was on abiraterone, and I had not had an AFib event for 15 years, and it gave me 5 in a matter of 5 years, and also gave me high blood pressure. So you do not want to get on that drug, for sure. Zytiga, it's not good if you've got a problem.
Bruce, your cardiac conditions, both of them sound like they're very stable. But nevertheless, if you feel like going to a group for people with heart disease and and prostate cancer. I have one that meets once a month, and we can put you on the mailing list. Do you want to do that?
Who, me?
Yeah.
Yeah, I think you're on it, aren't
I'm
you,
already
Brian?
on it. I've been to all your meetings.
Okay, sorry.
No, that's
Good.
okay. That's okay. Heck yeah, I'm on it.
I can
Yeah.
never tell where I've seen faces.
That's okay.
I apologize.
No, I'm on
Right.
it. Yeah, I go to all
Right.
those.
Okay.
Anybody have any words of comfort? That's what I'm hoping that we can pull out of this meeting for Brian. Anybody want to speak up and share your experience and tell him how well you're doing? If not, I'm going to pick on somebody because I've got somebody in mind who.
Yeah, so for me, for me, I would say
Yes.
that what really helped me a lot was a supplemental estrogen patch when I got on the Lupron and abiraterone, and it kind of jump started getting back in shape, and so that anyway, I would recommend if you start feeling down and fatigue and stuff like that, look at that.
Thank you.
Right. So we're going to go to Jimmy, but then I'm going to go to Bob Schwartz, because when I think about the condition that Bob Schwartz was in when he got here, and I look at him now, he's a vet. He's going to have some great words of advice, but I've given him a warning. Jimmy.
Very short, very short.
Yes.
In the men that I've seen and in myself, the beginning is the hardest time. Diagnosis, it's frightening, it's overwhelming. It's strange to say it, but it gets better once you know what you're dealing with. I knew what I was dealing with and what I had to do. And I've seen it happen time and time again. At the beginning, diagnosis is very, very tough. And then once you get on the road, you develop a fortitude and a strength that it might surprise you.
Okay. Thank you.
Okay, Mr. Schwartz. You can tell him what your PSMA scan looked like when you started this.
I got hit with the nightmare. I walked into a nightmare and I was lost. I fought many battles in my lifetime: guns, knives, bats, sticks, you name it. I've been there, done it. But this thing caught me blindsided. And when you get a PSA of 326.5, it knocks your sales right out. I was scared to death. I didn't know what to do. Fortunately, my wife found out about this group. I decided to give it a try. You've got a lot of individuals here that have wisdom, and more than anything, they've got the experience. They've been through it. They've been through the good, the bad, and the ugly. They will tell you the good things they've been through as well as the bad things, so you can learn from their mistakes, and they share them so other people don't have to suffer what they've went through. There's a lot of knowledge in this group. There's professionals, there's non-professionals, and there's all the in-between. Just take your time and relax. You've got time. I thought I was lucky if I was going to have 2 weeks, and now come November, I'm going to have 2 years. And I thank the guys on this group, seriously. The moderators, all the moderators, and all the people that have been on here, and the past ones. And that's a good thing, too. Look up the videos of the past and start reviewing them one at a time. Don't go too nuts. Just take your time and go through them. You're going to learn things. Some may apply to you, some may not. But keep it in the back of your mind, because if something comes up, you can go back to that video again and replay it. There's a wealth of knowledge in this group. And what I'll tell you this is, use it. And Captain Jim, you know that. I tell you, when we're in the vet meeting, in Jim, we trust. Okay? Well, in this group, it's a moderator. It's everybody. You know, and we also got the heart group. Dr. John, you know, I don't know where he finds the time to do all that he does. And he's amazing. And Rick, he pops in on everything. I wonder when he sleeps, you know? And then you get a chance to meet Ben someday and things like that. And Len, of course, is my island brother from Venice. You know, although he's cheating on me right now up in the Connecticut area, but he comes down here for the winter. I get to see more of them then. It's a great group of guys. It really is. It's a group you don't want to belong to. First want to tell you that. But I'll tell you this. I wouldn't want to be in any other group with the situation I'm in. They're helpful to you.
Was that good? I agree. That's.
Thank you, Bob. I knew I could rely on you.
Oh, good. I listen to all your stuff. When I'm walking, I have it on my earbuds. I'm listening to High Risk. I'm hearing it. I'm listening to all of it. So.
All right. Very good. We look forward to seeing you next week and hearing about your consultations as soon as you get them. Okay.
I'll be here. Thank you. You guys are lifesavers. Thank you.
Okay, welcome to High Risk.
Good to be here.
Okay, I'm going to start going down the list. I got Robert Anderson first. I'd like to hear how he's doing with his, well, I think it was daro mono last time we talked to him, and the PSA was in, let's see, 9.3, something like that. Catch us up, Robert.
So yeah, I've been on mono daro for I think 6 weeks. No,
That's all?
about no 10 weeks. It went down from like 9.32 to 0.01 in 6 weeks, and I just had my blood work done this week, and it's undetectable. The weird thing though is that my testosterone's still dropping. It's only at 150 now. That's all right. Thanks.
I know that daro is not supposed to drop your testosterone, but
that's what I thought. So, and I did have a quick question. Oh,
it's only a short time since your PSA was in the 9s, so I don't begrudge you the loss of a little testosterone at this particular point. Yeah, what's your question?
It's about bone loss, and I'm on Prolia, and my dentist of 40 years retired and saw a new dentist, and they say I need 4 teeth removed, and I've never had anything but a wisdom tooth removed. And I know that the Prolia can be it has something to do with the bone.
Yes, it does. Having dental work during treatment may put you at risk for a pretty unpleasant side effect. So if you have an endocrinologist that's prescribing the Prolia, get with them. And I'd be interested what other people have to say here, but get with them and see what they want to do before you start getting a lot of dental work done.
Okay.
Len, Rick, anybody else want to chime in on this Prolia dental work?
Well, I'm not even sure that I need it. You know, I mean, I don't know. I don't have any pain or infection, and the new dentist and oral surgeon that I went to is seeing bone loss around the teeth and a loose tooth. And these guys are in their 30s, and they're like, "Oh, we got to take care of that. We got to pull that out." You know.
Yeah.
I'm not even sure. I think I want to even get a second opinion from
definitely get a second opinion, because that bone loss could be related to why you're on Prolia in the first place.
Exactly.
Right.
Okay.
I was just going to say, I'm about to put a link in the chat window. We have on our blog a piece that was written by a dentist who he attended regularly. Sadly, we lost him. Called Bob Gamankin. God rest his soul. And he wrote this up, and I'm putting it in. I'm putting it into everyone right now. Everyone. Hold on, everyone. So there it is. There's the link. It says AnCan and says dental health at the end. So yeah, take a look at that, Robert, because that may help you. But I would exactly say what you're thinking is, let's get a second opinion. Now, here's another good thought for you. Several of the NCCN hospitals have dentists that specialize in oncology. And I don't know if Northwestern does or not, but I would look into it.
Oh, what a good idea.
I know that Memorial Sloan Kettering does, USC does, I think UCLA does. So there's a good chance that there may be a specialist dentist. And if there is, they're going to know about the impact of taking bone strengtheners like Prolia or Exgiva, etc. So please check with your Northwestern resources for a dentist that's strong on somebody who's on hormone therapy.
Okay. All right. Thanks.
And let us know if you find one, because it's a list that we should be familiar with. We can't rely on Rick's memory forever. You know, he knows everybody in every specialty, but we don't want to overload his brain. Okay, thank you.
All right.
For
Thank you.
updating us, and do it again soon. Let's go to Bill Agaman.
Hello.
Hi. Hello.
Should I summarize a little bit?
Sure.
All right. So I had a prostatectomy a year ago for a positive biopsy. And then the PSA was creeping up. And so I got referred to a radiation oncologist who I'd previously consulted with. And I met him, and I had a meeting with him, just the other day. And so the wheels are turning on getting set up for radiation oncology, radiation treatments. And there's I had another PET scan that was negative. I'll get another MRI that the radiation oncologist wants, and a CT, which has to do with just positioning for the radiation.
What's the radiation oncologist's treatment plan?
I don't know that yet.
Okay.
He's developing that, and I'll see him, I suppose, after the CT, which will be done at his facility.
Okay.
And it's recommended that hormone therapy of some sort during the radiation, and let's say my risk group is high. The Decipher was 8.8 or 0.88.
0.88.
And I'm a PT3A. What
now
else?
we want you to see medical oncologist as well.
I don't know if that is available. I will work on that.
Okay. That would be good, because so far I think you've only got a urologist. I don't think your radiation oncologist is the only type of oncologist you might need to see. As you and I have discussed at length, you have a number of risk factors, even though you're not metastatic yet. Now, a lot of times a medical oncologist, I'll be interested in Rick's position on this. A lot of times a medical oncologist might not be needed until the person becomes metastatic. But you have quite a number of risk factors. You're almost sure to progress at some point or other. And I think it needs to be known what type of hormone treatment, if any, needs to be done right now. Rick, would you think it would be inappropriate to get an MO at this point?
You know, it's really a practical issue given where Dr. Bill lives.
Yeah.
And now, I do think, if my memory serves me right, that virtual appointments may be available in Alaska from the GU medical oncologist Fred Hutch at University of Washington.
That would be great.
And you may want to look into that. And my feeling is, I mean, we're dealing with a recurrent situation. Isn't that right, Dr. Bill? Because you had surgery already, correct?
Well, we had surgery, and it was known that there were cells at the bladder margin. And the PSA was initially undetectable, and it's gone up. So
so we know we've got we know we've got recurrence.
Yep.
I would say yes. I mean, I would prefer to see, especially given that your radiation oncologist is local, I would really like to see you with a genitourinary medical oncologist that you're consulting with along the way. And probably I'd give you the same three names that we mentioned to Brian. Dr. Schweitzer is one. Dr. Shea, HSIEH, is another great guy. I know him from UCSF. And Dr. Yastrzewski is the third. And I would try and get on board with one of those three.
Spell Shea again.
HSIEH.
These are all in Seattle, I take it.
So these are all at Hutch. Yes, they're all at Fred Hutch.
Well, I'm not opposed to traveling for that matter. It's relatively easy. There's a lot going on, and so that's been sort of a back burner issue for me.
I think it would be good to do. I don't want us to be looking back 3 years from now and saying, I wish we had been a little more aggressive, you know?
Well, what I would want to know is, all right, so I have an appointment the day after tomorrow at the urologist's office, and they are going to help me with the hormone therapy selection. And Lupron is immediately available, and I'd be curious what the objections are, other than the objections I have in general about the whole damn thing.
Okay,
but
so
then getting to that would allow that would just be buying time to get the oral medications through the processing. And the radiation oncologist felt it would be important to be on some sort of hormone treatment during the radiation.
Oh, okay.
Yeah.
You could do it that way. If you are going to go on Lupron first, get on this drug called bicalutamide for a couple of weeks beforehand, just so you don't get a precipitous spike in your testosterone. We don't want to tip you into metastatic any earlier than is necessary. And then you could get on Lupron, and then if you ever have a chance to get on the oral medication, you can always do that. Go ahead, Rick. I'm sorry.
Yeah, no, I'm my bad because I interrupted you. Dr. Bill, this is a really good way to see how much your guys know. If they say to you, yes, let's do a Lupron shot today, then you know they're not on their game. And the reason for that is because the standard operating procedure with Lupron for men who may have spread is to put you on bicalutamide first, which is an old first generation ARSI drug. It's also, its commercial name is Casodex, and its generic name is bicalutamide. And by putting you on the bicalutamide for 10 to 15 days, we know that that will protect you if you get a spike in testosterone that promotes the cancer, because the Lupron is an agonist, and in order for it to shut off your testosterone, it has to make more testosterone first. And that's why the buffer is prescribed. Now, a lot of docs don't do it because they don't think about it, but it is a mistake. Now, if they give you an antagonist, which is like Firmagon, you're fine. So what I would say, if they want to get you going right away, and he says, we'll give you a shot of Lupron, you say, no, because you haven't given me the bicalutamide, please give me a shot of Firmagon first, which will last you for 4 weeks. And then by that time, maybe we'll get you onto the Orgovix, which is an antagonist like Firmagon, or we can talk about what next. If they do give you a Lupron shot, you've got to have the bicalutamide first, and don't take more than a 30-day shot, because hopefully we can get you onto Orgovix. Does that all make
Orgabaxine,
sense?
that's the oral one, right?
That's
Yep.
the oral one.
Okay.
Anything else, Bill, to catch us up on, or questions that you have before you proceed?
No, I think the main thing is that I'm going to be going to this appointment I have in a couple of days about hormone therapy. It seems is a clinic dedicated to that. And so we'll see.
Okay.
Well, again, our preference is that urologists should not be handling hormone therapy. They love to handle it because it's a cash cow for them if they give you a Lupron shot. But they're really not the experts. And we've seen urologists when you have side effects and you go back to the urologist because they gave you the shot, they say, oh, this isn't for us, this is for this. Go talk to your family doctor. Well, that's okay because you're a family doctor, so you can have a chat with yourself about these side effects. But seriously, we would rather see a GU medical oncologist involved because they're trained as an internist, or at least a radiation oncologist. But I understand why they're doing it.
I guess one of my concerns is I can go shopping for a GU oncologist and I can do all sorts of things. That'll take time.
Yeah, that's why I think we're saying to you, get a shot right now. You'll figure out how much they know if they advise you to get the bicalutamide first. But if they're only eager just to give you that shot, you know that whether they got a clinic or not, they're not on top of what they're doing.
Okay, well, we'll see. We'll see. My impression was that in this community, that's where this happens. And we'll see. The radiation oncologist set it up. So.
Yep.
But you won't get the shot without the.
Yeah. Well, good. That does help. Thank you.
It really does help.
Wait a minute. Did we hear a voice in the background there that we need to get to know?
That's my wife. She's a pediatrician. She really doesn't know anything about this.
Well, we like
name?
We like pediatricians, and we especially like care partners in this group, and we especially like them if they're knowledgeable in HCPs. So we invite her, just like Christine, to join in, and we can see her face, and we love, hello.
Hi there.
And if he's not listening to you, you'll have to treat him like one of your patients, okay?
He's told me this before. No, he told me I had to treat him like an attending, but and not a patient.
No, you have to treat him like a 5-year-old patient.
Yeah.
I think the information you gave, it's a good quiz for what we're dealing with, the group here. But on the other hand, it just was really good information because he won't get the Lupron unless he gets the pre-treatment first.
It's BI, right? Bicalutamide?
Yes, bicalutamide. BICAL. We'll put it in the chat window for you.
What's your first name, other doc?
Jane.
Jane.
Hi, Jane.
Okay,
Jane.
Dr. Jane. And Jim Marshall's already put it in the chat window for you.
All right.
Okay.
All right. Thanks.
Okay, more to come. Yeah, I feel like your disease is sitting right there at the threshold, ready to go, and we want to put a roadblock in its way.
Yep.
Okay, I've got John M. next. Where are you, John? Oh, I see you. John, I can't hear you. Still nothing. Keep trying and I'll circle back to you. Okay, John? Bruce Shrimps and Rick, is there anything you guys want to discuss in this group?
Well, I think the issue is that Bruce was clearly very upset about having to be on hormone therapy, and blames the drug for a lot of issues because he wrote a long rant about being on the drugs. And I think we all agree with him that nobody wants to be on hormone therapy, and we don't like what it does to us. And we agree. But at the same time, can we blame the drug? And the issue, Bruce, is, I think as difficult as it is, most of the guy, and we've all done hormone therapy, we may not be on it now, but if you're in this group, the chances are you've done it or you're going to be doing it. How do you come to terms with being on this drug, which is, in Bruce's language, an evil drug? How do we accept that and still take it? Because we don't see what it's doing for us on a day-to-day basis. It seems to be doing bad things. I mean, I do have an answer, but I don't want to color the conversation. But is there anybody in the group who would like to address that? Is there anybody else who's felt really hostile towards particularly the ADT, the androgen deprivation?
I think that there are probably 40 of us who are hostile to ADT.
So, John, you kick it off.
Yeah, well, Bruce, my main worry about Bruce is to make sure that you get active follow-up and don't, stop seeing your doctors over this. You used to be on Orgovix, I think. And are you still non-detectable for your PSA?
I am non-detectable right now. I am on Orgovix right now, and will be on it until the end of October.
Okay, so the issue is whether to be on a second drug or not. Is that it?
I asked my oncologist about that, and he said, I don't think that would be a good idea. That's all he said.
All right. And did you ever have any genetic testing, Bruce? Maybe there's some way around it. What did you have any mutations?
I had that at the Mayo Clinic, and there is no way around it.
Okay.
So, one way around it, if you can convince them, because it may make you feel better, is what a lot of the guys are doing on here, which is getting off of the Orgovix and going on to darolutamide. Because it does work. We've seen it work. The men feel better for it. Another thing to do, which is, which is maybe more controversial, is and I think you consider this, is the E2, is the estradiol therapy, because you don't feel so bad on that. But I mean, this is less about, the choice of drug, although I do think monotherapy darolutamide would be a great conversation for you to have, but more, how do we accept all these side effects that these damn drugs do to us, and why do we accept them?
Well, in my own research, I have discovered that ADT therapy, particularly for prostate cancer, has been around for 85 years. I happen to be 80. I had no idea it was that long. And it seems to me that in 85 years, the medical societies or the big pharmas would have come up with something to deal with prostate cancer, and they have not. And I have the sneaking suspicion, no evidence of it, but sneaking suspicion that the people who are in the know on this stuff, which is the medical societies and the pharmaceutical firms, are happy to have it lean into a long-term chase of trying to control the cancer with ADT without really coming to a solution. I think the chase is the solution in their head. And that might be very unfair, and it might not even be factually correct. That's certainly the feeling I have.
Well,
So
yeah, I
how
mean, as a grade group 5 person, we would have to say that despite all these years, we haven't progressed to a cure, just only management. But
that's correct.
There's a lot more drugs than just ADT now. I mean, in my particular case, I got an excellent response to ADT. It's done an awful lot of harm to my life, but I'm still here. So to me, it's a good deal, even though I've paid dearly for it. Rick, you were about to say something.
Yeah, I mean, it's hard for me to accept that we haven't found anything to treat prostate cancer. Even since my diagnosis, which was in 2007, the number of new treatments that have come through and are extending life for many, many men, there's got to be a dozen of them, if not more. All of the ARSIs, the PARP inhibitors, if you've got a mutation, the RLT, the radioligand therapies, which extend life. Now we have something for men who have a P10 mutation. So all of the precision. So to sit there and say, but nothing's happening. No, I mean, there's so much happening. It's hard for us to stay on top of it. I mean, Len, what would you say on this?
Rick, I agree 100%. There have been an incredible number of advances. There was a time, if you go back to 2004, all you had was a poor response to a chemotherapy drug, mitoxantrone.
Yeah.
And if you failed ADT, it's pretty much the end of the line. Now, as you mentioned, Rick, first of all, they have a much more effective chemotherapy drug, docetaxel. There's a backup drug to that chemotherapy, carbazitaxel. There, as you mentioned, all the others, RLTs and PARP inhibitors.
Look at the advancements in radiation therapy.
Yeah, that's true. Radiation therapy, they used to butcher people with, they'd wind up with colostomies because the radiation was just scattered all over the place. And now it's highly targeted. I would say for you, Bruce, if you really can't tolerate the ADT, that, as I think Rick or someone mentioned, darolutamide monotherapy might be a great option for you. Most people find that there's very little fatigue because it doesn't pass into the brain. So, definitely talk to your doctor about that. And the other thing is, I worked in the pharma companies. There's no conspiracy to keep people. The researchers are not trying to deliberately not achieve a cure. They're doing their damnedest. They want to win a Nobel Prize. They work long, hard hours, and they're dedicated to finding cures if they can, or at least to extend life for people with cancer. So, don't buy into that whole conspiracy nonsense. That's my opinion anyway.
Let's hear from Bob Schwartz, then I'm going to move on because I still got a dozen left. Bob?
Yeah, Bruce, I'm going to speak to you like a military man. I know you're military. I'm former military. Dr. John and I have talked about this before, and we're on the same page. Your quality of life goes down a little bit, but your longevity increases, okay? So it's a choice you got to make. It's not an easy choice. I know I would not have volunteered to take any of the medicine I have to take. It sucks. And then I had to go through chemotherapy, one of the worst things I ever had to go through in my life. But guess what? It was worth it, okay? I wouldn't want to do it again, but if I had to, I'm going to. It's not something I'd like. But if it can help me get my longevity going, fine. But the quality of life, yeah, you have to give up some things, but it's a choice. And like a friend of mine used to say, you want to be above ground today, or you want to be below ground. It's a choice you make. You know, it's a hard way to do it, but that's why you got to look at it. It's apples and oranges. Which one do you want, and which one means more to you? I made a choice, and I'll pay for it, but it's my choice, and I'll stick with it. Thank you.
Thank you. Okay, I'm going to move on. There's one guy I know has to leave early. That's David Lead. And if anybody else has to leave early, put your hand up and let me know. David, let us know what's on your mind.
Yeah, I had said I only needed 30 seconds, and I just got another PSA result this morning, and it actually went down. So this is now the fourth PSA reading since my all-time high. So I'm very excited about that. So it seems to it's either a plateau or it's actually going down.
What'd you get for a number?
Well, again, I had a prostatectomy, so it has to be pretty low. My number today was 0.11.
Good.
Anything we can answer for you, David?
No, I don't think so. I'm just really enjoying the conversation, and I'm writing a lot of drugs down and a lot of things that I hope I don't need because I haven't been on any drug or hormone therapy yet. But I appreciate all the back and forth, and I'm taking copious notes. I don't know how to spell any of these drugs, but I'm sounding them out. I'll have to look online after we're done here tonight to get the correct spelling, but I really appreciate the group. Thank you.
That's great. David, by the way, slipped away before they got him into the radiation therapy chamber and has had dropping PSAs ever since then. So yes. That was a good escape.
Yes.
All right, very good. Anybody else have to leave early? Okay, let me try again for John.
Can you hear me now?
Yes, I can.
Can you hear me now?
Yep.
Okay, very good. Excellent. I was on ADT for 13 months, and I was undetectable on PSA for 10 months. I had a confident conversation with my GU oncologist, and we agreed that I could leave ADT in March. My first post-treatment PSA came in at 0.13, and I got my second one this past week, and it was 0.1, so it's going down a little bit.
Excellent.
I was all excited, and he said, "Hang on. You're under surveillance now, right?" So I'm on the long path, but it's a good path. So I just want to pass along the good news.
Well, that's great. So how much total time were you on ADT?
I was on ADT for 13 months, and I brought along the JAMA article when I went to meet with my oncologist, and I said, "This article says I should not be on ADT any longer." And it was a very interesting conversation, but in the end, he said, "Okay." So it was really good. So I'm on the path. I'm just on the path.
Yep. You probably have a testosterone level by now.
I do. It went from undetectable, and we're just short of 230 now. Just short of 230. So I got to lift some weights, and I don't know, do what else, but I got to get that up. But at least I've got a little bit of testosterone, so headed in the right direction. It does.
How long was that again?
How long?
Since you quit the ADT to where you are now.
In March. I quit in March, and I've had 2 blood tests, and my PSA was very low, 0.1, right? And my testosterone was like 229. And the second test was slightly lower. It was 214, so it went down slightly, but that's on me. I gotta do the work.
Well, it varies a lot also from hour to hour, so you can't expect it to be right on the button every time. But that's good. You were on Orgovix, and that's probably why you got a good testosterone level by now, I imagine. We had a guy in one of my groups.
I had Orgovix
in one of my
abiraterone
groups last
therapy.
week. Yeah, abiraterone. We had a guy in one of my groups last night that was in a similar situation. He said he was starting to have hound dog thoughts. So let us know when you get your hound dog thoughts back again.
Okay, I'll let you know on that. Okay, all right.
Steve Lodge.
Good day.
Good day.
Hold on. You had a hand up, John.
Oh, I did? Who was it?
Richard Craymond.
Go ahead, Richard.
Richard Craymond, did you have your hand up? Or you do have your hand up?
I'm sorry, I'm doing
Go ahead.
Hit the wrong one.
Yeah, we can hear you.
What is the JAMA reference?
I think I know what.
John,
I think I know.
Go ahead, Rick. Go ahead.
No,
Rick,
I think
you know
I
it better
know.
than I do.
Why don't you cite it? I think you're talking about Kishan's paper, Kishan and Spratt's paper.
Yeah, they did came out in November, November 2025, and it was a collective study of ADT and prostate cancer cure rates of men with high and medium risk prostate cancer, and it's a very interesting article. And so it basically recommended that if it's a gland-defined disease, non-metastatic, if it's non-metastatic, their study found nobody should be on ADT for longer than 12 months. It's non-metastatic.
Richard, would you like somebody to look up that reference for you, or is that enough?
No, I have it. I'm about to put it in. It's not really pertinent to Richard's situation, but I'm going to put it in right now. I'm just going to call it the Kishan Spratt, and I'll put it in.
Thank you very much.
Yes, I'm definitely metastatic.
Back to Steve Lodge.
Thank you.
Yes, I've heard of, I think, some of the folks here alternating between PSMAs and whole body MRIs to find any cancer mets that may be developing. And I've never been high PSA. At diagnosis, I was only 4.5. So I'm thinking that might be a good plan for me, and I'm just wanting other people's thoughts.
Well, that's a great question. You know, generally PSMA is more sensitive for those men who express PSMA. For other people, no, we have to think back to other types of scans, you know, like whole body MRI or other types of specific prostate cancer scans. Let's collect some comments about that. Anybody? Steve, have you had a PSMA PET scan?
I've had two. The most recent one was a year and a half ago.
Was it able to show the disease in your body? Was it positive?
It did show some mets, and my first one also did. So at least some, if not all, of my cancer is PSMA positive.
So let me check with my co-moderators about this. This means that at least at that time, you had PSMA positive cancer. Your PSMA scan reacted to treatment the way you would expect it to do. We don't really have any evidence up until now that you have developed a new mutation, for example, a rising PSA level despite treatment that had been working before, or new metastases despite being on a treatment that worked before. So maybe it could be argued that for somebody like you, PSMA PET plus PSA would be a perfectly good surveillance method. Until such time as you suspect a metastasis. Could Len or Rick chime in on that, please?
So I really would like to hear from one of the gents who's doing this alternate treatment that we've talked about in this group. Is there anybody here who's doing PSMA and then alternating it with a whole body scan? If there is, please put your hand up. Don Rogers. So Don, if you're doing that, what are your thoughts for somebody like Steve Logan, or what were your thoughts for yourself to accept? Why did you accept that protocol?
Unmute, Don, please. Don, unmute, please.
Here we go. Yeah. I had a long chat with Dr. Belusic perhaps 3 weeks ago on this very issue. And he thought, with me, I've been undetectable, PSA undetectable for over 2 years now. And he just thinks it's very reasonable to alternate the two scans. In fact, he said if you wanted to do one every 6 months, it's fine with him. He didn't think it was necessary, but it was fine with him. He was cautious about doing PSMA's PET scans all the time because he did have a concern about the exposure to the radiation. And I won't talk about that here. It's a very small dose. I understand that, but I had, with the radiation treatment I had 68 gray, and he was concerned to try to keep that down as low as possible, the total exposure to radiation.
Well, there's a good point.
Anyone else has anyone else had that discussion with their treatment team? So if we don't have anybody, I think Dr. Belusic has a very good point. My own personal feeling is that you've had so much damn radiation if you did radiation therapy, that the amount of extra that you're going to get for these scans is marginal. But if you're really concerned about how much radiation you're getting, then yeah, I mean, it's a way to go. That said, I think probably if you are PSMA avid, you're better off with a PSMA scan if you really want to know where you're going. If you're not PSMA avid, that's a whole nother situation.
Great question. Great question.
Are you happy, Steve L? Steve L, is that okay? Can we move on?
I guess I'm trying to figure out, how do you know that some of your cancer is not PSMA avid if you don't do these other tests?
Well, my 2 cents about that is that either your PSA or your scans or your symptoms advance despite treatment. Rick, is that it's probably what you were going to say?
Yeah, that's a great answer. Okay. That's a great answer. I mean, if you're stable and nothing seems to be happening, you don't have pain and everything else, you do another PSMA scan. Now, if that PSMA scan it's probably going to show something. If it comes up absolutely clear, then the question is, am I still producing PSMA? And then it gets into a discussion we're actually having live right now with Blue Earth, which is, well, you know, maybe we could check an Axumin scan. But again, we know that with Axumin, for it to show anything, you've got to have a certain level of PSA. So,
okay.
But I think it's a discussion you can have with Dr. Fong.
Yep. All right, thank you.
Tell us what he says. I'm going to move on to Avery. This is probably about your struggle for an oncologist. I don't know. Avery, are you still with us? Avery?
Yes. Update is I got a I do have an initial meeting with Dr. DeVilla, the radiation oncologist at Sibley, scheduled for next Tuesday. And hopefully we talk about a plan. I left him, I took him my scans, all of my discs, and all the records from Walter Reed, and they looked at it. So I have that. I tried to, Dr. Haller is next door to him, and I went over and I provided everything to her to try to get a initial appointment. And I got a call today that she is no longer taking new patients because she's moving on from, I assume, from Sibley. And I don't know if any other individual that is have treatment with her knows that, but that's what was given to me today.
Okay. Anybody else got Dr. Paller? Okay. Do we know Dr. Patilla, Rick?
Yeah, Jim Marshall has Dr. Paller. So that's at least one. Anyone else here? And Jim Marshall, have you heard anything about her moving along?
Negative. Also, Hank, let's see, Hank Zajic has her too. Nope.
And yes, and we have other people that do. So we haven't heard that, Avery, but and who is the radiation oncologist that you said?
Dr. DeVilla. You recommended him.
Oh, Dr. DeVille. Yes, that's who we recommended.
Yeah.
He's really good. So
yeah. I have a question.
What I would say is go see Dr. DeVille and ask him, you can't get in to see Dr. Paller, but you'd like to talk to a med-onc, who would he recommend?
Okay, that was my question.
Yes, that's probably what we do, because we don't have another name, or I don't have another name off the top, and I'll look. But I would trust Dr. DeVille, and unless he says, well, this lady that you got up in Baltimore is okay, in which case I think he's giving you the you know what. But you say to him, come on, Dr. DeVille, I want the straight scoop. Who can I see down here who's as good as Dr. Paller?
And didn't we talked about Dr. Mandel or somebody at Hopkins for Avery? Anybody remember?
Yes, but that was the doctor that they sort of pushed him on to, who's a cardiologist. She's a cardiologist, but she recently became an oncologist.
That's right. Yeah.
Right.
That's okay. Thank you.
So I would lean on Kurt DeVille. Okay. And if not, we'll come back with another name. I've got a couple of inside tracks that we can use, and I can ask somebody I can ask somebody to help you out. But see what DeVille says. We haven't heard anything about Dr. Paller. I just kind of think they don't want to set you up with Dr. Paller because you're not advanced enough. That's what I think. And they're giving you this excuse. They're giving you the bum's rush on Dr. Paller. But hopefully I'm right, because we don't want to see Dr. Paller leave Sibley.
I think that those that are have her for treatment. I mean, there may be something that they can ask once they go in and talk with her. It's just, yeah.
I'm sorry, I'm not hearing you that well. Speak up.
I think those that have her for care, not
Yes.
currently, when they talk with her, just it's maybe something that they can ask her or chime in, just to ask her.
Great suggestion.
Yeah.
And okay, and it's so good. We're going to task Jim Marshall.
Yeah,
Well,
I do want to say one more thing. I'm glad that I'm seeing Dr. Davila next Tuesday because I was scheduled to get a Lupron shot on next Friday. So I'm going to hold off on that until I do just get more information. And I'm going to let him know that too.
And see what he thinks. You know, I mean, we've got enough evidence that maybe you shouldn't even be on these things, and maybe you need, what you really need is primary treatment and not hormone therapy. Jim Marshall, maybe you can drop Dr. Pallett a line and say, "I heard you might be leaving. Is there anything to that? And if there is, who's the best person to see if you're not here?"
Dr. Markowski is the one that you've referred to before. Markowski.
Oh yeah, thank you. Yeah.
What's the name again?
Markowski.
Okay. The wonders of my chart. The wonders
you.
of my chart.
Yeah. Richard Cramen, isn't that who you see, Markowski?
Yeah. I think I started it back when he was in Baltimore.
Right. Great suggestion. Thank you, Jeff Markey. Great suggestion. Markowski's a solid backup.
Jeff, is that what your hand is up for? Okay, very good. Let's move on to Chuck and Christine. This is a Gleason 5+4 BRCA2 just getting rolling person. Go ahead, catch us up a little bit and tell us what's going on.
I think we're probably in the same place we were when we first met with you guys. He's just farther along in that actual treatment. And it's just kind of, or it feels like a kind of a limbo place. He had a PET scan, a PET CT prostate GA68 PSMA scan on July 1st, and that showed no cancer. And then in October, he'll have a PSA. He's doing the Lupron shot with the Zytiga and the Prednisone.
When did that start? Because I don't have that. When did the Lupron and Zytiga start?
Well, he started the biclitamide or whatever that is on November 26th. And then it was a week later that they gave him the Lupron shot and the Zytiga and the Prednisone.
Oh, okay. Okay, that goes all the way back to after the surgery then.
Yeah, it was after the surgery. And then he started radiation.
And wait, excuse me a minute. There was a PET scan last year that showed positive lymph nodes.
Yes, and that is why.
And now is there a new PET scan now that's all negative?
Yes, after the radiation and the ADT, which he started the ADT on November 26th. Basically, we had a meeting with the radiation oncologist. He gave us the biclitamide at that appointment, took that. A week later, had the Lupron shot, week and a half later. And then we started the radiation. He had 8 weeks of radiation in November 2025. And so now we're just kind of, his medical oncologist has him on hormone therapy for 2 years, is what she's telling us. And it's just kind of, you know, they've told us it's stage 4, But then she says, but I have a guy that has it, he has it for 20 years. And then I say, well, okay, Chuck has a BRCA2 gene. And she's like, well, but there's that. And then we leave and we don't know what to think. And it's just
a little bit of discussion last time of maybe getting you to a BRCA expert, wasn't there? Were we going to have you see Dr. Munster or somebody that specializes in BRCA2?
Yeah. So I'm struggling. I'm struggling a little here because I can't remember your last name. I'm so sorry. I do remember the case.
Oh yeah, it's Edwards.
Edwards. So I think we suggested to you that the closest to you, because aren't you in DC and aren't you getting treated at Inova?
Idaho.
Boise, Idaho.
Oh, you're in Idaho. No, I'm way off base.
No, that's okay. But Chuck, I think it was the Hutchinson Center in Salt Lake, or one of the. Yeah, he had a phone call with them and basically told them what his treatment was, and they agreed that that was the correct treatment and didn't think that he needed to go anywhere.
Okay.
We have met with a genetic counselor, and then who referred us to a website called The Force Hereditary Cancer, something blah blah blah.
Right.
And so they get emails all the time about different webinars they're having and stuff. But I just felt like we just want to stay on top of the latest and greatest treatments for him, and also kind of.
Right.
He has a Gleason score of 9. I don't hear a lot of people having Gleason scores of 9, and I don't know if that's because they're all dead or we're just not hearing about it.
Well, I have a 9, and I'm still here.
And if I ask everybody on this call right now to put your hand up, and then we'll take it down, who has for people who have a 9, you're going to see an awful lot of these hands up go on. There's so many people that have 9s.
I'm sorry, but yes.
So yeah, I'm sorry. I was thinking that you were somebody else completely. So do we have you on our BRCA Brothers list? Are you getting that BRCA Brothers email? If not, I'll make sure you go on right after this.
I think you are, because I think there's an event in October and we have it on our calendar. We missed the latest one.
Yes, we are doing on the 31st. No, not in October. We have an event coming up on August 31st, the last day of this month. And it's going to be genetic counselors speaking about genetic counseling for families with inherited mutations. So it's going to be specifically for families with inherited mutations. And hopefully we're going to have 2 genetic counselors, one from UCLA and one from the Ohio State, the James at Ohio State.
Good.
And then we're hoping that Dr. Munster will either host or present, since she is a peer in that group and comes from a family with a BRCA. So put that date down, and you'll hear more about this in the next couple of weeks.
And let me say, you sound a little bit like you're worried that maybe everything isn't being done. So you've had surgery, radiation, and doublet therapy. We've got PARP inhibitors, of course, in the background. I can't put my finger on anything that maybe should be being done, especially is the PSA still non-detectable? Yes.
Yeah.
Okay. But does anybody think that there's anything that should be being done that's not? I want to reassure these guys that they're getting the most thorough treatment possible.
No, I mean, I think you've just got to work out the time. Probably 2 years is right. Could be a little bit less, but somewhere between 18 months and 2 years. And then you can think about taking a break and hopefully it's gone. But just like Dr. John said, there are a bunch of treatments that we can go to next. And, you know,
is the goal, because initially, before the surgery, we didn't meet with a medical oncologist. We only met with the surgeon and then the radiation oncologist. And at that time, he was telling us, the radiation oncologist was telling us we were going for a cure. And that's what the surgeon was saying, we're going for a cure. And then after the surgery, when the PSA had gone up, and we met with a medical oncologist, she said, no, we're not going for a cure anymore.
Yeah, but here's the problem. They should never have told you you were going for a cure. Because we don't know how to cure 5+4 prostate cancer. And they knew when they told you that you were 5+4.
Yeah.
So their language,
go ahead.
Let me finish. Their language was not right. The best we can do is what a bunch of us live with here, which is a durable, continuing remission. So we don't know how to cure cancer this bad, but I say 17 years out and I had stage 3 and I was a 4+4. And every year I go back and it could come back. And we've had guys where it's come back after 17 years, after 20 years, and it happens. So this is why it makes me a little nuts when we have healthcare professionals talking to you about cure, because it sets your expectation in the wrong place.
Yeah.
And I would tell that to your radiation oncologist and your urologist face to face. And usually what they say is, well, you're right. Yeah, it can come back. But they use this cure word and it's just misleading and wrong. I'm sorry, Christine and Chuck. It just should not have been used in the first place, in our view.
Yeah.
I've got a hand up from Bruce. Go ahead, Bruce.
Oh, my hand's not up.
Oh, I just took it down because I thought I was calling on you. Okay. I do want to respond to Pierre's question on there, but I don't have time because I've got so many people. So maybe if one of my co-moderators could respond to Pierre. Christine and Chuck, can I move on for now?
Yep.
Okay. Bob Y, you're next on my list.
Hey, Dr. John, thanks very much. I've been in Europe for a while. I'm back in Los Angeles, so I'm happy to see all of you folks. I just wanted to get a kind of a read from people on my situation, and maybe you can help me. I had 5+4, later changed to unknown caller. Who's calling me on the phone? Go away. Oh. I had a 5+4, later downgraded by a different guy to 4+3. But anyway, I had radiation treatments in January and went on Orgovix and Nubeqa in January. I did reasonably well with both, but started getting leg aches in the spring, which I thought was simply due to those drugs. The leg aches got worse and worse, and I contacted my medical oncologist in June, telling him that I just couldn't get to sleep at night. My legs were hurting me so bad I could not fall asleep, and I was exhausted. After several weeks, he suggested I stop both drugs for a month and see how I did. I stopped both drugs for a month. The leg aches continued. It gave me no relief. And so I eventually decided I would restart both drugs because, you know, better to get the cancer protection than not. And the leg aches continued. I've tried every possible drug, including gabapentin. The only thing that that is able to sort of relieve the pain and let me get some sleep at night is basically light dosage of morphine sulfate, which I know is a little scary of a drug, but there it is, it works. Lately, though, in the last few weeks, I've begun having weakness in my legs, particularly in the hip and just all parts of the legs, really weak, where I have a hard time walking, hard time getting upstairs and so forth. At first, I thought this must be related to muscle atrophy due to testosterone that is practically zero. I met with my primary care doctor this morning, and he said, but you don't have muscle, you only have muscle weakness in your legs. I said, yes, that's correct. He said, you don't really have muscle weakness in your arms or upper body. No, I don't. He said, well, then it's possible that the muscle weakness is being caused by a lumbar issue. That is a swollen disc that is impinging upon the sciatic nerve, for instance, because I have had sciatica symptoms in the last couple of months too. And so I wondered, given my symptoms of leg weakness, real leg weakness in the last few weeks, is it, I guess I should be exploring both the lumbar issues and the drug issues. I have an appointment coming up with my medical oncologist, and I'll discuss that with him. It's Dr. Posadas at Cedars-Sinai. And I have a video appointment with Dr. Kishan, my radiological oncologist at UCLA. And I've gotten an MRI, so I'm going to take a look at those results. But I just wondered if anybody had experience with leg weakness as opposed and not upper body weakness.
I'm wondering if I could call on Bill E. to offer an opinion about this. A patient with lower limb weakness and pain who has gone off his new medications for a whole month without any relief, and the syndrome appears to be progressing, and it's bilateral.
Well, it wouldn't seem to have anything to do with the medicine.
Right. Yeah. I guess you need a good neurological workup. Yeah, Bill?
I think that's the case. Yes, my primary care doctor this morning put me in touch with a neurologist and said, yes, you need a neurological induction scan or something like that, because that's what he thinks. So that seems to be the most likely. So I'll proceed with that, and I'll let you all know what I find out.
Okay, very good.
Thank you.
Thank you, Bill. Dan.
Bill, appreciate it.
You're next on my list.
Yes. Just an update. I'm still waiting for the MRI of my spine because I have lower back pain and have a lesion on my T10. So he wants to do an MRI before he starts doing any treatment, just to make sure where the pain's coming from. And I've been having trouble with my local hospital and MSK. My local hospital keeps changing what they need. And so I had MSK, I talked to them, they will call local hospital to see exactly what they need so I can get that MRI done. And Dr. McHugh said he will do the liquid biopsy to see, what mutations or DNA the tumor has. And I found a local hospital that will administer the Pluvicto for me, and so that's like 18 miles away, as opposed to a 3-hour ride. And the complication of that, having Pluvicto and then to be able to travel, the complications that that has. And then I also found a local urologist that I had that did my surgery actually, and he said he would he would administer Lupron for me on 3 months basis, and that's in the works right now. And he also did a PSA and testosterone test on me, and my PSA went up to 5.0 569, and my testosterone went to 44.6. So that's just where I am on my update. But I have a couple questions. It seems like the brain fog is getting worse, and I'm exercising, eating right, and my sleep. I could be getting bed earlier, but that's not that bad. So I was wondering, if there was anything else I could do to relieve the brain fog.
What drugs are you on right now?
Abiraterone, prednisone, and the Lupron.
Okay, so what we would say, and I think we've suggested this to you before, is you need to ask McHugh to put you on darolutamide, or maybe even monotherapy darolutamide, because that's going to help you.
And that's in addition?
No, instead of the abiraterone, or even
Right,
possibly instead of the abiraterone and the and the Lupron.
I think that your testosterone is too high, so you're, I think, in for a change anyway.
Right.
You have to have better hormone treatment for both of those reasons.
But hold on a minute, John. When was the last time you had your Lupron shot?
In the early part of the year, I'm due for one now.
Okay.
And so I
now. Whoa. You're due for one now, or you were due for one a month ago, and you're going to get
the beginning of August.
The beginning of August, and they gave you a 6-month shot at that time.
Yes, and in February, 6 months.
So that's why, and I remember telling you at the time, this is why we don't like 6-month shots. People always say, well, what's wrong with it? Because at the end of that 6-month shot, they don't work that well.
Right.
And what you're seeing is your testosterone going up because it hasn't lasted 6 months.
Right. Yeah. Right.
And so that's why your PSA is going up. So what we've got to do is get you now. If I recall, we wanted to try and get you onto Orgovix, but the VA won't give you Orgovix in New York. Is that right?
I'm not on VA treatment at all.
So again, we always ask you to dual register, because if you dual register, there's a good chance you can get your Orgovix through the VA.
Yes.
Excuse me, Rick. Here we are getting him approved for the free health care as we speak, but it will take a few months.
Okay, so you're on the track to dual register. Is that's what you're saying, right?
Affirmative.
Yes.
Right. So in the meantime, is the issue that you can't get Orgovix right now because of your insurance?
No, the issue is that because I'm going to take the Pluvicto, he says the Pluvicto people said it's better to start the Pluvicto treatment and then change to the Orgovix.
Okay, but you need it now. And that's not, and so whoever the Pluvicto people are, I don't know, but there's no reason why you couldn't start Orgovix today or tomorrow.
Okay.
Now, it is not like you are going to stop Lupron. Your Lupron isn't working. You need an ADT drug right now. The best ADT drug for you to be on is Orgovix. So you've got to go in and say, I want the Orgovix. As far as the abiraterone is concerned, we would say talk to McHugh about switching to darolutamide. You will have to come off the prednisone slowly. Although I remember last time you just stopped it and it didn't, it was okay, but come off it slowly. and replace the abiraterone, ask about replacing the abiraterone with darolutamide.
So do I not take the Pluvicto? Should I not take the Pluvicto at all, or just?
No. Let's keep it simple. You're in the Pluvicto trial, right?
No.
I thought you were in the reciprocal trial.
Yes, they were going on with that, but now I have to get the Pluvicto administered locally.
So you're going to get Pluvicto locally,
right?
And not participate. And how many treatments are you going to get locally?
Until it stops working, and then I'll stop.
Okay, that's not how it works, Dan. Unfortunately, because you can't get an indefinite number of treatments. You can get up to 6. So you have to have an understanding with McHugh whether you're going to do the full 6 or whether you can stop beforehand.
Yes, I talked to him about that. He said I could stop before 6.
Okay, so we're going to see how you do on Pluvicto locally. And you have to have hormone therapy with that.
Right.
And the hormone therapy should be Orgovyx, and talk to him about switching from abiraterone to darolutamide because you've got too much brain fog.
Right, okay.
Very good.
We got to move on. I'm sorry, Dan, but Dan, bring your wife into these discussions.
Okay.
I've met her and she's really sharp.
Yes, she is.
And I think you need her. Because I feel like sometimes we're talking and it's hard for you to get it all down whilst we're talking. But I think if your wife is next to you, it's going to happen.
Yes, because it's mostly the brain fog that's caused that. Usually I'm sharper than this, but the brain fog got me.
Got it. Yeah. So bring your wife in to help you so that we can execute these plans.
So listen, guys, Len, I'll get to you in a second. I've got 5 people. There's another group probably in a half an hour. I'm going to go as long as Rick lets me. If we don't get to someone, you can either write to me if you have a pressing question at dr.john@ancan.org, or if it's not a pressing question at all, we'll just put you on next week's list. Len, I think that's your group next week, and I owe you one, so I can do next week for you. But let me see what Len has to say, and then I'm going to go as far down the list as I can get. Go ahead, Len. I got no mic, Len. I've got no sound.
It's that headset. Yeah, I think your headset is the issue, Len.
Unplug it, see what happens. No.
No, we heard you before, but somehow or other, it's not picking up the microphone from your headset. Unplug the headset.
Yeah, can you hear me?
Yeah.
Yes.
Yeah, the headset is really so I can hear, but you can hear me without it. So for Dan, being that you have the brain fog, I'm just wondering, could your rising testosterone be a result of a lack of medication compliance? Are you sure you're taking the abiraterone when you should every day and then the right amount? Yes?
Yes. On a occasion, I forgot to take it, or I set the alarm, turn the alarm off, then take it, like that. But generally, I'm compliant with taking that.
Okay, that's it. Go ahead, John.
Point. Always a great question to wonder when a drug's not working, is it actually getting into the patient's body? Steve Schuler, you're next if you're still here. Steve?
Yes, I am. So, so my situation, well, I want a little bit of advice about getting my testosterone back. My situation is I was on ADT, and it's kind of complicated because it was Lupron, abiraterone, and some estrogen, but not all at the same time. The reasons are not being able to get onto it initially like I wanted, but at any rate, I was on ADT for 3 years, which ended at the start of February. And my testosterone so far has gone from undetectable to 14, according to Fred Hutch, their assay, and still 0, according to LabCorp. So I'm not getting it back, or at least not getting it back very quickly. And my question is really, is it too early to declare failure and look to testosterone replacement, or should I be a little bit more patient? It's been like,
I'm going to cut to the chase because of time. Even though there's a lot of testosterone experience in this group, I'd say give it several more months.
Okay.
How long have you been off?
I've been off. I've been off everything for 7 months.
For 7 months. And how long were you on it?
3 years, basically.
Oh. Way too soon. It's way too soon for you to even be thinking about T replacement.
Yeah.
Even in my own case, I was
no, Rick. I'm really sorry. I don't have time for any more.
Okay, but we do have time, John, because if we don't get to people, we'll get to them next week. Right?
All right. That's
yeah. Anyway, my question is not so much how is it going to take a long time for any testosterone to come back. Is the speed at which it's coming back, which is not fast,
right? We
on
don't
the low end of the scale.
Everybody's different. Yeah. Everybody's different, Steve. So in my case, I didn't have any testosterone come back for at least 3 or 4 months. Nothing. After 6 to 8 months, it suddenly came back. And that was quick. Now, you were on hormone, you were on ADT for 3 years, right?
Yeah.
The old rule of thumb, which doesn't really hold, is it can take as long as you are on for it to come back. It could take 3 years. I would give it at least a year, at least, if not a year and a half. And I don't think anybody would give you T replacement until you've done that. I mean, what experience do we have in here of T coming back? Can anybody else give? My T was 540 when I went on. I was on for 28 months, and I got back up to around 300 or 400 within about 9 months. But it didn't go up in a regular fashion. It was nothing for a long time, and then it started to come up. Don Rogers.
Mine went from 0, raised slowly over a 6-month period, and right now it's in the mid 400s.
Okay, and how old are you, Don? Because it's also a function of age, Steve.
I was on 80
yeah,
for two full years. I'm 74.
Right.
And I'm 70, almost 71.
So, and in my case, at the time I was 50 something. When I came off, I was 59, I think, 58 or 59. So it takes a long, long time. So there's nothing unusual. Now, if you came to me a year from now and said I'm at 14, we'd say, yeah, that doesn't sound right. And there are some people where it doesn't come back that quickly and it never comes back. But yes, Jim Marshall, but you were close to 80 when you came off of it. And you see, this is what people don't get. It's different for everybody, and your age is very, very important, because naturally your body stops making so much testosterone as you get older. Older men have lower testosterone. Younger men have higher, and so it comes back quicker.
Shucks.
Okay.
Right.
I mean, I guess I'll have this conversation again in like
have it again,
3
but
years,
I mean, to
6
think
months or
about
something,
but to think about
Yeah.
testosterone replacement 7 months after you came off of the ADT, when you were on it for 3 years, it's just
I guess the reason let me put it this way. So if my testosterone was, say, 50 right now, I wouldn't be asking this question. But the fact that it's 14 according to one assay and 0 according to a different assay after 7 months, that makes me think it's not happening. But
it's just slow. Like Don Rogers saw nothing for 6 months, and then it started to come back. And that's, some people are
right.
like that. Other people,
Patience it is.
John
Enough said.
Maxwell. John Maxwell was only on for 12 months, but his testosterone came back really quickly. And he was on Orgovix, which is also helpful, because it seems to come back quicker when you're on Orgovix. But we don't know. Everybody's a little bit different. Everybody's different. But I think you're really jumping the gun. And I think that you got to talk to your docs up there in Seattle about what to expect when you come off. Have you had the discussion with them?
Well, this is why I joined today, because I've got the discussion coming up on Thursday. So.
Okay, so and is it Schweitzer? You see, I can't remember.
No, it's her name is Rajitha Sankara.
Right. I mean, I think you just got to have that discussion with her, and it may take time. And if it takes time, so you have to hang in. But I don't think it's that unusual. It's slow, but it's not a drastic slow. That's
okay.
I can't give you the medical advice.
Thank you. This is what I wanted. I wanted some feedback, and thank you for. I will be patient.
Anybody else have anything to say on this one? I mean, about testosterone coming back, or experience with testosterone coming back? Okay, John, what I think we should do at this point, because the most we're going to have is time for one more person, is let's create the list of who you still have on your list. So for Len, for next week.
Richard Craven has volunteered to go to next week. Okay. I've got Barry, Damon, and David waiting.
Barry, David M, and Damon. Damon, are you going to be with us?
Move me to next week.
Okay.
Yeah,
Damon,
I'm not sure. I'm not sure. I'm not sure. I still work. I was just gonna give a quick update, but
okay. So let's take you and David. Is it okay if we defer you to next week? Yeah. So, Damon, give us a quick update.
Oh, I had my two HDR. Oh, there I am. My video came on. I had my high dose radiation last Tuesday and yesterday, and that's done. I start my external beam SBRT in a couple weeks. The interesting thing that happened, so after last week, there's a lot of pain, there's a lot going on in your body, and I took a bunch of ibuprofen. I actually had my blood test on Thursday. This procedure was last Tuesday. I had my monthly blood test on Thursday. My liver enzymes shot way up. My AST is 6, ALT at 118. And I was just wondering, has anybody experienced that? I mean, I just had all this stuff go on. they're going to retest me. I'm going to retest this week, but that was a little wake up call that the liver enzymes, I don't want to have that organ fail, of course.
And what drugs are you on right now?
Oh, I'm sorry. I am on Orgovix and then Abby plus prednisone.
Okay, Dr. John, you want to handle that one?
So your liver tests are something like 3 times what they should be.
Yeah, the AST is about 50%, and the ALT, yeah, it's like almost 3.
Almost 3 times. So any further increase than this, you're going to have to get off some medications in order to give your liver a break.
Okay,
so
that's what they were saying. Yeah.
Yep, get another test fairly soon, within this month, and if it settles down, good. If not, you got to get rid of something.
Okay, because I was just wondering because I did have a bunch of ibuprofen, not a bunch, but some of it because of the HDR, right? It's I was wondering if that would have caused that much of a spike.
Yeah, usually the ibuprofen is a little harder on the stomach and platelets and kidneys than the liver, but yes, the liver is also a potential target. So that's why we have to repeat before doing anything.
Okay, yeah, I'll probably get one later this week, another test.
Good.
Anyway, that's my update.
Okay, and where are you? Where are you being treated?
UCSF.
UCSF.
Yeah, so it's Dr. Sue did the HDR yesterday.
Okay. So make sure that Dr. Shu and Dr. Small know that your ALT and AST are very high.
Yeah, they're aware.
And have you asked them what you should do?
Well, I've talked to I don't actually talk to Small. I talked to his team and all this stuff. I have an appointment with him in a month. But they did imply that, if it didn't come down, they would take some of the Abby down, or so, they would do what Dr. John just said.
Right. So you've got 2 good docs there. That's the first thing. The second thing is we know that abiraterone can cause significant liver issues. And we also know that on occasion the ADT can. It did for me, but it wasn't as high as this. I was treated at UCSF, and it never got into normal range, but it was high as long as I was on it. So this can happen, but I think that what Dr. John said is exactly what UCSF is doing. So we can only confirm. Did you have any other specific questions?
No, that was just an update on the radiation and just this question about the liver enzymes.
How's the hot flushes?
They're bad. They're bad, but I think they're getting fewer per day. Is that normal? I've been on it since mid-April.
Yeah. Did you try the Ember or haven't gotten your hold of one yet?
Oh, I got my Ember on right now. Yes.
Okay.
Yeah.
Maybe that's why they're a little better.
Yeah, I think it's helping. Yeah.
Did you read our wearables? Did you read the post that we did on wearables? Miss Kim just came in for a second and she left, but we have to thank her for that, our MS moderator. Okay. But in the reminder last week, there was a post. There was a big pink flamingo, and an article. I wish you could. It sort of drives me nuts a little bit because we put this great stuff into the reminders, but a lot of you guys don't read them. So just cast your eyes over it. There's a terrific post on our website on wearable cooling aids. We've got the Bob Alvord personal swamp cooler, evaporative cooler. But there's a whole bunch of options, including Ember.
Yeah.
I want to make a big plug for Rick's invitations and write-ups. There's a tremendous amount of information in there, and it's really great. So slog through it. You'll almost always find something.
It always comes in. It always comes in on the beginning of the weekend. So open it up, take a look, and cast your eyes over it, and say, "Oh yeah, I got to go back and read this." But That's why we put it in, to help you, gents.
Now, what did we decide to do with Barry? Are we?
Barry's next week. So Len, you please make a note that David.
I think I'm going to do next week, Rick.
Okay, well that's between you and Len, but
yeah, I'll probably do it.
David M. and Barry and Richard Kramer. I would prefer we save you in case we need you for the last week of the month. But that's between us.
Well, I'm willing to do it, John, if Rick wants to save you for the designated hitter.
Yeah, because we haven't heard from Ben, and I don't know if Ben's going to be here or not, and so.
All right, I'll be saving myself for my husband.
Guys, we got to get out because Miss Kim came in once, and I don't want her coming in again. But I am going to tell her that her wearables is very helpful.
Good meeting, all. Thank you.
Good night,
everybody.
Thank you.
Goodbye.
Yeah.